Some may say it's impossible. But if you can reduce your weight by 20 kg, the blood pressure, your systolic blood pressure can drop by as much as 18 to 20 millimeter mercury. That is the best antihypertensive that one has ever discovered. But you have to drop 20 kg. No, 10 kg, sorry. Next, low salt and low protein diet has been shown many times in big publications to be of beneficial effect in prevention, as well as preventing deterioration of chronic kidney disease. I think the last speaker, the dietitian, will talk to you guys in detail about this. And last but not least, smoking cessation. Most of us associate smoking with heart diseases, associate smoking with lung condition. But less known to us, smoking cessation has been proven to reduce the chances of developing chronic kidney disease, as well as preventing it from deteriorating at a phenomenal rate. And for some reason, you've developed hypertension. As mentioned by the first speaker, we apply a stricter control, an optimal target for blood pressure control as compared to a population. General population, if you're free from CKD or other cardiovascular risk factors, the general consensus is about a blood pressure of 140 over 80 millimeter mercury. But in CKD patient, as you have heard by now, and I hope all of you are convinced by now, you belong to a higher risk group of patients for developing cardiovascular events. And hence with it, the target has been set much lower. We're aiming for a target of 130 at 80. And most of the patients who are on CKD, especially the middle and the end-stage CKD patients, you definitely need more than one antihypertensive agent. So as what Dr. Grace Lee has said, do not bargain. If you want to treat it properly. On the minimum, you need a two at least, antihypertensive to control a end-stage CKD patient who has hypertension. Same thing applies for diabetes, because now you're at a higher risk group. A stricter diabetic control target has been set for CKD patient. We're looking at, on average, a HbA1c of around 6.5% on a regular visit. Certain class of medication we can employ to treat CKD or to prevent the development of CKD. I'm just going to highlight two classes here. That is the ACE inhibitor, as well as the angiotensin II receptor blocker medicine, known as ARBs. What these two groups of medicine are basically antihypertensive agents. That means they lower down your blood pressure. But on top of the blood pressure lowering effect, they do have the effect to reduce your protein. They do have the effect long-term wise to retard kidney function, kidney deterioration. And hence 3-in-1. That's what I always tell my patient. 3-in-1 function when you use one of these agents. I mean, in the interest of time, I'll not go into detail individual medicine associated with it. You may want to explore it with your GPs or doctors. As highlighted by the first speaker, once for some reason you develop CKD, you not just have to treat your CKD, we have to manage the associated complication. And the associated complications are that of anemia, has been highlighted, because now your failing kidney cannot produce optimal amounts of hormone to keep your blood level there. So that's one problem you have to tackle. And anemia by itself is associated with worsening of your heart problem. Last but not least, bone diseases as well. As you have heard, the calcium, the phosphate, and the vitamin D metabolism pathway has all been disrupted when you develop CKD. So a lot of attention has been paid for by the kidney specialists as well when they treat a patient with CKD. And I'd just like to round it up by saying CKD is a fairly common condition. It is, unfortunately, a silent killer, asymptomatic in most cases in early stages, and here lies the importance of screening. And I thank you all for your attention.